Hi, my name is Megan Tarvis, and I am here to present my flashcard on an organ transplant rejection. So, the disease process is when an organ transplant occurs when a damaged or non reliable organ or tissue is replaced to continue normal function. Depending on the type of organ it is or tissue, the human body may detect it as new foreign tissue and can cause rejection to occur. Inflammation and necrosis can occur and eventually will destroy the new organ or tissue, demanding the need for replacement or medication. So, the pathophysiology, there are three types of organ rejections: hyperacute, acute, and chronic. Hyperacute occurs immediately after the organ transplant. This is often usually diagnosed in the operating room because of how quickly it occurs. It's often rare, but because of the successful rate of cross matching prior to surgery. Acute occurs weeks after the transplant due to unmatched antigens, and then chronic organ rejections can occur at a more gradual pace over time, and these are the most common. So the human leukocyte antigen, known as HLA, can help the immune system identify cells in the body and foreign cells. However, HLA mismatching can result in acute rejections. Adaptive immunity is a specific response which allows T memory cells to recognize specific foreign antigens that enter the body. So things like pregnancy, blood transfusions, and other transplants can cause a patient to be sensitized to HLA antigens. Therefore, T cells, the memory T cells, are created specifically for HLA antigen that go against the antigens, and a rejection occurs. T cell mediated rejection is where T cells can recognize the antigens in the lymphoid tissues, and they begin to migrate with chemokines, creating up pro-inflammatory substances, which can include inflammation, necrosis, like I said, and organs can not function anymore. So risk factors for organ transplant rejection include immunologic factors. Like I said, HLA mismatch increases the risk of acute rejection and death. Donor-specific antibodies is another risk for organ rejection. Foreign antigens are exposed during the transplant, and donor-specific antibodies often fight the rejection, which the lack of survival for specific organ or function. Other factors can increase the risk of rejection, having younger individuals as patients receiving the transplant, an older donors, the function of the organ or tissue starts to decrease, less effective. Like I mentioned, younger recipients are unable to metabolize immunosuppressive drugs well, so rejections can occur. They also found evidence that the African American population and genetic predispositions are more at risk as well. They found that kidney transplants are more successful with the white population rather than African Americans. Signs and symptoms depend on the organ and what type of rejection it is. For example, pain at the local site is because of the inflammation and necrosis occurring within the transplant organ or tissue. Infections can begin from the lack of immune response from the HLA compatibility. Infections can include fevers, nausea, vomiting, and fatigue. A patient with kidney transplant may experience algeria or no urine output because there's no longer functioning the new organ. Symptoms are based, like I said, on whether they're acute or chronic. In order to diagnose, we want to find the presence of HLA antibodies, the mismatch of HLA in the donor and as well as the recipient, and the donor-specific antibodies that can be detected within labs, specifically the Luminex bead-based panel screening. We also want to assess biochemical indicators for specific organs. Biopsies can often detect inflammation, necrosis on tissues or organs. For example, a liver biopsy detected a hepatocyte necrosis in one study. HLA testing is also important to detect the presence of leukocyte antigens in the body and see if they're compatible with the donor and the recipient. Evidence from another study showed the ELI spot assay can be done prior or after the transplantation to prevent the risk of rejection. This test looks for the presence of memory of T cells and B cells that can be detected. As I mentioned, the memory T cells often create antibodies against HLA. Changes in labs can occur depending on the organ. So you want to obtain a CBC, a CMP, a BMP, and urinalysis. We can also obtain chest x-ray, ultrasound, or a CT, depending on the location of organ and tissue that is needed. And as well as treatment in organ rejections managed with immunosuppressive medications, which are often seen in everyday practice. Patients are often at risk for infections because of the suppression of the immune system. So we want to monitor risk for infection as well. And thank you for listening.